Good morning. I'm going to go ahead and just say right up front that I really hate speaking to a computer screen, so I'm just going to pretend you guys are all sitting right there. And for some reason, you're really quiet today. I want to go ahead and say, watch this video. If you have any questions, send me a quick email. I'll be sending out the test before I travel next week, so you'll have about a week to watch this. I'm going to go really quickly through the slides and just talk about, highlights and lowlights of what I want you to pick out of these things or what's kind of useless. Hopefully you'll be able to see the screen. After I'm finished recording, I'll figure out if I want to email it or if I can upload it to YouTube or whatever we need to do. So let's go through these slides real quick and have you guys ready to take your test. The test will be the same format as last time. You'll have 5 questions, pick 3. You guys have done really well so far. I've been super happy. Go do the teaching evaluation if you haven't done it yet. I want to make sure everybody does that. I'm going to be sending out emails. You probably have one before you even watch this video. That's it. Okay, so on the screen now you should see the slide about health policy and healthcare policy. So what's the difference? We know that when we pass health policy, the idea there is to make some sort of policy that has direct impact on health, right? So if you make legislation to eliminate indoor smoking in bars, the direct result of that is reduction of primary and secondhand smoke exposure. So what's the impact on health if we're going to measure it in the evaluation stage? Well, that's a reduction in lung cancer, asthma, cardiovascular disease. We use terms like morbidity and mortality. So that's a review from the first half of the class. We're talking about health care policy, though. We're not actually talking about the direct impact on health. Instead, it's an indirect impact, right? So you increase eligibility for Medicaid, more individuals have health insurance, so there's increased preventive care, increased management of chronic disease. In the long run, we would hope to see some sort of reductions in illness and death, but it's not a direct line, right? It's indirect. If you remember, if I had a whiteboard that I could scribble on here, it would be health is not equal to insurance, is not equal to access. Okay, those 3 things are not the same. They are related to one another. We hope that as we increase access to health care, we increase health. But access is not the same, and there's reasons why. So a test question might ask you to describe why is health, access, and health insurance not the same. And you could talk about things that are important related to that. Next, we're going to talk about the healthcare's iron triangle. And you might hear me drink coffee. Hopefully it's not too loud, but I've got a cup of coffee here that I'm drinking while I'm doing this lecture. Quality, cost, and access. When you move one of these levers, it's going to move the other 2. You need to know, why if I change quality, does it change the other 2? What might the impact be if I increase access? How does that impact the other 2 pieces? And of course, there's times where, I increased access, so if I don't want quality to change, I've got to really increase cost because it's going to pull on that piece of the triangle and you're going to have to arrange those 3 pieces so that the cost might go quite a bit higher because you have access and you want to keep the quality up. Otherwise, you might keep the cost the same and raise access, but then the quality is going to decrease. So those 3 things are tied together, and whichever one that you change, if you increase quality, it's going to increase cost. It might decrease access. Just think about the amount of time people spend with providers or those kind of things. So those 3 things are linked together. That's the iron triangle of healthcare. That's one of the key components, one of the key things that you need to know for this class. We talked a little bit about types of healthcare systems. The real important part here is that, they range from private financing and private providers, meaning that the providers aren't government employees, to having a lot of intervention by the government, so having a lot of public financing, a lot of public providers. So there's a range in that area, and so from the U.S. over to Cuba there on this graph, you can see. But the important part is, there's a difference between how much intervention there is, how much private financing, how many private providers, and of course everything's moving towards the right side of this table now. The United States has done more government financing. There are a lot of government providers, although there are some with the military health system. But the U.S. is kind of way over there on the left in this graph versus some of the countries that have more public financing and public providers. So the doctors and nurses might be public employees. It's just another way to look at it with some of the names that people use. So, moving forward, especially if you're going to go into healthcare, you're probably going to take a deeper class than this on the healthcare system. Think about that, the Bismarck system, the Beveridge system. And you would learn a lot more about that in detail if you took a deeper, more in-depth healthcare class. The Bismarck model, Germany, the flagship, right? So the payments come for the employers and the employee pay withholdings, but everything goes into like one pool. Everybody receives coverage, but the trade-offs there are providers may not be paid as well. You can run out of funding. So if they use all the money up out of the government system, it's just over. Unemployment can be an issue. As unemployment rises, they have less money in that pool. The Beveridge model is kind of what we normally think about when we think about a nationalized healthcare system. This is kind of the UK Canadian model. Taxes basically pay for everybody to have coverage. You don't pay anything when you go to the point of service. But depending on the country, there are some differences. In some places, the doctors are private. Other places, they are government employees. And the issues with that one are the wait lines. So that's the idea that people are running out of Canada or to Buffalo to have surgery. The idea that taxes can be high, and this idea of rationing healthcare. So you have to pick. We talked about the choice of where we're going to draw the line. We're not going to cover you at a certain point. Of course, when we talk about rationing, we also talked about how that happens in the U.S. healthcare system too, but it's usually based on income rather than, like a scientific panel. So we talked about how in like kind of the American psychology, that's okay because we're okay with, people having financial reasons why they can't receive it, but we're not okay with a panel of experts choosing what's covered and what's not. It also happens in our government healthcare system. So Medicaid, Medicare, there are things that we cover, things that we don't cover, and those are decided, at a policy level. So we talked about insurance. What is the purpose of insurance? And so you'll remember the purpose of insurance has nothing to do with protecting your health. It has to do with protecting your finances. So you're basically saving people's income if there was some sort of health issue. You don't want people to go bankrupt. But that's kind of oxymoronic in the United States because healthcare is really what's driving us under, right? So as the costs are going up, it's been a big pull on employers and on people, and it's a major financial issue now. But it was really made to protect you from losing your money. So we talked about the one person example. So if Marco is selling health insurance, right? What's going on? You're paying Marco every month, and then if you realize that if you get sick, he's going to cover that. So you receive the benefits because you're paying them. So in a one-person example, it's very simple that you're paying a certain small amount of money per month in case something were to happen to your health, so that you wouldn't have to pay all that money out of pocket. Marco would cover it. But then it gets a little bit more complicated when we talk about risk pooling. So if you remember risk pool, this is when I was drawing the smiley faces up on the board, right? As a risk pool, a lot of people pay in, and then it offsets the cost to the individual because a lot of people are paying. It offsets the cost to the insurers because, again, if they have all those smiley faces in their risk pool, they're very happy. They're getting paid by all of them, and they have less risk that they have to pay out all the money that they've earned to date. So we drew different examples of a risk pool. We drew a bunch of happy faces, and we talked about that. We drew a bunch of unhappy faces. One of the things that I emphasized was once you open up insurance plans, the risk pool to pre-existing conditions. Once you open it up to, you get rid of out-of-pocket maximums, you get rid of annual maximums, that risk pool all of a sudden looks a lot worse to the insurer. And so what do you have to do? You have to subsidize those costs. You have to raise premium costs. And so that's an issue. Now, one thing, I can't remember how much we discussed this in detail, but people were worried that, well, when Medicaid expansion happens, all these unhealthy people are going to come in. This risk pool is going to look really bad because people haven't had health insurance for years. But what we learned was the expansion population actually were a bunch of happy faces. It really wasn't that sad when it happened, because they were people who had either had some general access to health care prior to through sliding scale services or free clinics, but additionally they were young. And so those young folks came into the marketplace or came into the Medicaid expansion. They really didn't have serious health issues in general. And so it wasn't as bad as people thought they might be. But just remember, we drew those different examples, and so those will be helpful as you think about the test questions. Pros and cons. For the consumer, well, health insurance is really good if you have to use it. You're paying in monthly those premiums. You can remember the example that I gave you of my old boss down at the state, Pisnu. He kept a spreadsheet. He showed me how much money he'd spent. He was really upset that he hadn't spent all that on trips to Disneyland. So depending on, as a consumer, how much you use the health care, it really depends on whether or not it's a bargain or not. What about for healthcare providers? Well, for them, sometimes health insurance can be great because it helps them not be limited in their practices. It can help them, bring in folks that they wouldn't necessarily get if they're part of an HMO or a grouping that the healthcare has. Right? It might give them a stable patient base. It helps them to have to, not have to advertise and go out and get providers, those kind of things. But it does come with some administrative headaches. So, we watched the video about all the billing and all the different funny things that happen. You can remember that there is some sort of, administrative headache piece that goes along with that. So we talked about private health insurance before. We talked about public health insurance. Private can be either for-profit or non-profit, and the bulk of that in the United States, as we'll see in a later slide, is employer-sponsored health insurance. Most people in the United States that have health insurance have employer-sponsored health insurance, but now we also have a growing, or it grew a little bit, individual marketplace after the Affordable Care Act. We talked about all these terms. You should be familiar with them. We won't go through them all here in this review, but just knowing what all these terms mean, it's difficult. We talked about, and I think I went to the website and showed you the PIA booklet. These are decision-making pieces that people should be making when they're choosing health insurance funds, but it's very difficult for them to choose. As we get into the ACA piece in a second, we'll talk about how some of this stuff changed. But the terminology is very important as you study insurance. So then we transitioned our discussion from private health insurance to public health insurance in the United States. Talked about Medicare, Medicaid. Of course, there are other types. We didn't spend a lot of time on it. If you take a health insurance class, you might learn more about it. Medicare Part A is the hospital. It's inpatient insurance. It takes care of you if you check into the hospital. Part B is that outpatient, what we usually think of as health insurance. Part C is Medicare Advantage. That's A and B combined and offered by private companies. Part D is the prescription drug piece. Eligibility for Medicare is you have to be 65 and older, or you have to have a disability. A permanent disability is defined as something you've had for at least 24 months. The disability piece, as someone asked, came in through President Nixon in 1972. We also talked a little bit about that donut hole, right? So that's the idea that it's closing, so next year it'll be gone, but people would have to pay a certain percentage of their health insurance. Once they got to that hole, it meant they had to pay all of their prescription drugs, and then when they got to the other end of that hole, Medicare kicked in and paid about 90% of the price of those prescription drugs. So that donut hole is a really odd, policy gap that happened. Medicaid, on the other hand, is health insurance for people who have lower incomes. And then there's some higher eligibility criteria for women who are pregnant, children, and individuals with disabilities. The disability piece, again, kicked in with President Nixon. The children's piece we use is called CHIP, the Child Health Insurance Program. There are a lot of individuals in the United States who are what we call dual eligibles. They have both Medicaid and Medicare. One of the key differences between the two programs is that Medicare is federally administered and federally funded. Medicaid, on the other hand, is administered by the states and it has a cost share. It's a state-federal cost share. There's an agreement in place about how much the state provides in funding versus the federal government by percentage. And so that means there's budget implications, which are important for the Medicaid expansion. It means states have to think about where they're going to cover that because they have a constitutional, every state constitution says they have to have a balanced budget. So they have to think about how to either raise taxes or raise other types of revenue, or they have to cut other programs, which is more likely what's going to happen. And then because it's a state program, benefits can vary from state to state. All right, let's switch over to the next set of slides on the Affordable Care Act. So, costs were rising. They have been rising. They're still rising after the ACA, maybe leveling off a little bit more. But why do we care? Well, there's those budget trade-offs that we talked about. The states have to figure out where to raise the revenues or cut other programs. And what other programs can they cut? Where it's education, transportation, the biggies. The middle class, as healthcare costs rise, they have to pay more in premiums. It means they can't save as much, buy houses, spend. So some of the sales tax revenue is gone, and so it has this kind of shock wave to the economy that happens as a result of rising healthcare costs. Employers, they have a higher burden. They may not be able to hire as many people. They have to pay a higher chunk of money. They can't invest as much money in research and development and other things. And then there's a rising number of people who are uninsured. So leading up to the ACA, this was no shocker. This was an issue. We had to deal with it one way or another. So the Affordable Care Act was the way that Congress decided to go about addressing these rising costs. The key components of the Affordable Care Act that we have, there's the individual mandate. That's the one everybody has to have health insurance, right? Very controversial, that piece. That was also, as we talked about in the risk pooling discussion, right? If you're going to allow people with pre-existing conditions, if you have an individual mandate, that brings a lot of healthy younger people into the insurance marketplace, offsets those risk pools a little bit for the insurers. If you take them out, if you get rid of the individual mandate, as the newspaper article, that I was quoted in the Register Herald and Beckley talked about, you take those people out of the marketplace, and you don't have that individual mandate. How do you make up for that? Do you have to subsidize it somehow? Do you have to make a state-run high-risk pool? So that can create some issues. But basically, the Affordable Care Act forced everyone in, so that made the risk pool much healthier overall. There was also an employer mandate. Said anybody who had more than 50 employees in their within their employ had to, pay. They had a mandate to help cover some part of their health insurance. If not, they could be fined. Children under the age of 26 can be covered under their parents' insurance as dependents. Pre-existing conditions no longer allowed for coverage denial. There was an elimination of annual and lifetime benefit limitations. And then there were some other public health things that we talked about that were also funded through the Affordable Care Act. The Medicaid expansion, big things to know. It expanded the Medicaid from individuals at 100% to 133% of the federal poverty level. So in 2017, again, you see there, that's $32,718 for a family of four. It's not a whole lot of money. Originally, the Medicaid expansion was supposed to hit all 50 states. Some states sued, said you can't force us to do this because it's coming out of our budget eventually. Supreme Court said you're right, it's unconstitutional to require them. So some states decided to expand, some decided not to. The trend has been other states expanding. More states have been doing the Medicaid expansion. Seems to be working. People seem to like it. It's been popular. Why not expand? Well, again, the budget issue. After the first 3 years, the states have to start kicking in some portion of that. And then after, I think it's 5 or 6 years, the state has about a 10% requirement to fund the expansion population costs. So that budget issue may be a reason why some states have been hesitant to expand. But again, the trend has been more states picking up the expansion. On the other hand, the health insurance marketplaces, which was borrowed off that Massachusetts model. We talked a little bit about the Massachusetts Health Connector, what it looked like. The idea there was, well, if we have this open marketplace, there's competition, it makes everything more affordable. We'll offer subsidies to people under 400% of the federal poverty level to help them. We're going to have health plans. They're called qualified health plans that have specific, conditions in them. So those health plans have to meet certain standards in order to be offered through the health insurance marketplace. And then they're offered through this online website that you go on, you can compare the plans, you choose one, and you can receive a subsidy based on your income through that health insurance marketplace. Originally, every state was required to set up their own health insurance marketplace, but due to another federal Supreme Court decision, you can't force the states to do it. So states could either set up their own, they could enter into a partnership where there was shared responsibility between the states and the federal government, or they could default to a federal system. The trend there has been to go towards federal marketplaces. I think this slide's a little confusing the way I worded it, but the state base going down means that states are moving away from that. It was split pretty evenly, but states realize that there are really high information technology costs. There's really high, costs for the call center. And so for, a state like West Virginia, for instance, if we have 40,000 people who are eligible or using the marketplace, that's not a lot of folks to be spending millions of dollars on IT and call center costs. And so letting the federal government run it or having some shared responsibilities makes a lot more sense than spending a lot of money on a small population within a state. Where do we go from here? Well, the election happened during our class. There was a slight, Democratic pickup in the House of Representatives, but the Republicans have the Senate, the Republicans have the presidency. It's really hard to say if we're going to see any kind of major changes in healthcare. Obviously, there has been some weakening of the individual mandate. What will we see as a result? Will insurance premiums just go up because we still have people with pre-existing conditions in them? Will government come up with some alternative solution like high-risk pools or subsidizing those? Will we turn to an option of Medicare? So will Medicare be offered as an option, competitively with these private health insurance plans? Medicare for all would have huge economic and business repercussions, right? So health insurance companies fund huge amounts of our economy. So if we went to that, it would mean a lot of upheaval in our economy. Will we continue the Medicaid expansion? As states have to start picking up a percentage of that, as that percentage has grown to around 10%, our state's going to continue to buy in. What happens if a state decides not to be a part of the Medicaid expansion and we go the other way? We had a vote about that in the last election, but it's important. It's important to think about what will happen there. Will the marketplace continue? And then again, the individual mandate's basically gone. So how is that going to impact things as we move forward in healthcare reform? So the last set of slides that we want to review are kind of what I call the fun slides. We'll talk about those very briefly. starting at the beginning here. We talked about managed care versus fee for service. The big thing I want you guys to take out of that, you can look at the table here. You can pause and take a look at it if you want. But the big thing is there's kind of perverse incentives on each side, right? If you're fee for service, you're incentivized to do more services in order to get more fees. But if it's managed care, you may have an incentive to do less. So you may not do as much as you should because you can keep more of that. And again, the plan has an incentive there to deny services because they can keep part of that rate as their profit. Here's a link if you type it in. I don't know that you need to, but it was just a funny video about the guy going to the hospital and why the costs are so high. Talked about a lot of important things such as the cost of insurance plans and why it's so important. It talked about health insurance, and why hospitals can't give you a price, and why things are different from insurance plan to insurance plan, from geographic region to geographic region, and talked about pharmaceuticals and the high cost of those based on research and development. So everybody's pointing the blame at everybody else. We talked about moral hazard and why that is an issue, that some people may engage in behavior undesirable from the other party. We talked about why with health insurance there's the waste. Right, so you might get too many healthcare services because the insurance is there. And then this funny comic, I like it anyway, about the risk pool. This young and healthy guy standing there, and then there's the old sick folks in the Shark Tank saying, "Come on in, the water's fine. He's young and healthy. Why does he want to be in there?" Right, that damages the risk pool. On the health insurance side, what happens? If I go shopping, I can get my Lamborghini. I know a lot about it. I can see the reviews. I know that's a great vehicle. I can know a lot about it. But if I'm trying to choose a doctor, it's way harder to do. I'm likely to get this quack, and it's whether it's doctors or health insurance or figuring out what treatments to get. The health insurance and the health care piece is very difficult for consumers to navigate. We talked a little bit about health care coverage versus personal health care expenditures and who's covering what. You can see, again, employer-sponsored is about half of the country, but the payout is mostly in Medicare. So Medicare has a disproportionate amount of spending versus how many people are enrolled. And of course, that's because there's a lot of older people in Medicare and individuals with disabilities that might have high healthcare costs. Again, I won't wear you out with these slides, but the idea that that we're not getting the outcomes that maybe we should based on the cost that we're spending compared to other Western countries, that's a major note that you would hear in a healthcare class, and talking about how again we don't do so well. Lots of duplicate medical tests. Infant mortality rates are really high. Our cancer system does pretty well. We use the emergency room a lot. That might be changing a little bit with things like MedExpress and the rise of these urgent care systems, but it's still just a big issue for us. Why do we care about the emergency department? That's a question you should at least be familiar with at the root. It's 3 to 4 times more expensive than other types of care. There's no continuity of care, so you come into the emergency room and you leave, and there's not, usually no tie back to your primary care physician. It's episodic, so we're not necessarily getting you in some kind of long-term management. There's not much in the way of preventive services. It's just bad, basically. It costs a lot, and it's not good for long-term health. Again, we spend a lot of money, so just in the difference between what we spend and what Switzerland spends, that $15.5 trillion, we could cover South Carolina. Since none of you are from South Carolina, we should cover it in solar panels. Again, costs across countries radically different. Our financing is incredibly complex, so you can see how we pay. There's out-of-pocket payments that we spend to providers, but also subsidies from governments to individuals and to the healthcare providers. Our taxes go to the government and pay for things like Medicare, Medicaid. We pay premiums. You can just look at this and see how wild and complicated the U.S. financing of healthcare is versus a single universal healthcare model, right, where you just pay taxes to the government and then the government pays the providers. That has a lot of costs built into it. All this complexity costs a lot of money. Think about all those papers moving back and forth in the video that we watched. Let's see. The cost piece is important. This is a map around New York. Somebody pointed out there's some Jersey here too. But look at how wildly the costs vary, even at hospitals pretty near to each other geographically. This is only a few miles. And there's wildly different costs in those hospitals for the same treatment. U.S., we spread out where you can get vaccinations. Another example why costs are high. So if you can get vaccinations at all these different places, we have to be able to bill all those places. There has to be paperwork at all those places. There has to be insurance that covers the shots at all these different places. There's not much of a relationship between at least how CMS and AHRQ measure quality and what costs are. So you might say, oh, I'm getting great health care because I'm spending a lot for it, but that's not necessarily the case. The quality is not related to spending as far as how we measure quality. All right, and I think that's about it. We ran through the slides. Important things. Again, know the big picture, know about the health insurance piece. Watch these slides. Send me any questions that you might have. That was a crash course in healthcare insurance policy. The basics. If you want to go on and take another class, that would be great. Either we'll offer it or, again, I am going to offer the idea that some people might want to take an independent study in the spring. If you do, let me know. We'll figure out what that class might look like. Otherwise, I hope you've enjoyed the class. I've really enjoyed that you guys were talking a lot and we had some good discussion in the class. Go do the teaching evaluations. As soon as they open up, I'll send you guys an email so that you can get on and do it. And other than that, let me know if you have questions and good luck on the test. Thanks a lot.